Plan a vitrectomy in a simple recurrent vitreous hemorrhage, known case of myopia with diabetic retinopathy. So after parasoplana approach, separation of the anterior alloid from the posterior alloid in order to clear the view and proceed directly for core vitrectomy all over around. Luckily, this is, as I've mentioned earlier, myopic case, so PVD in most myopic cases, as we all know, it's been induced. Continue core vitrectomy. Check the bleeders. There is no more bleeder. And next I proceed for the shaving with indentation. At the same time, exploring the periphery if there is any breaks, as it's been seen here. This is a case of high myopia, so the challenges might be risk of iatrogenic breaks, measured breaks. The large globe, this patient axial length is 30, so the handling process inside the globe, it's a little bit challenging. However, it will be easy once you get the hang of it. Continue shaving. Swap your hands. Luckily, this is a pseudophakic eye, so it's well known that for the crossing is forbidden in a phakic eye. But it's much easier to swap your hands half-half, so to continue all over around shaving. However, many vitreoretinal colleagues advise that in the case of simple vitreous hemorrhage, mission accomplished once you've done the core vitrectomy and there's no need for shaving. I prefer to continue shaving, treat the bleeder, do indentation, and continue everything in the best way, inshallah. So it's a large globe, so you have to rotate the globe in order to achieve the other side with indentation that help. The visualization system is something more challenging in every vitreoretinal future surgeon. So getting the visualization and the agility and the mobility all over around with the illumination, it's something that takes time to be adjusted and get used to. Well, here the shaving is being continued. The retina is flat. And next, it's time for endo laser. Starting from the far periphery and all over around the arcades. And after finishing the endo laser, I will do FACS, fluid air exchange, by maximum vacuum using the cutter. And then if there is residual fluid, I will use the flute. And this is what I've done. By using the flute needle aspiration, the residual fluid and the area of hemorrhage. As it could be seen here, the flute's barely touching the surface. Now it's been bright, kept on air as the tendon has sclerotomy sutured. There was significant improvement post-operatively from hand movement to 624. Thanks for watching.